Welcome to the University of California, San Francisco Sports Medicine Podcast featuring Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdown discussing hot topics in sports medicine and society.
Welcome to this week's podcast, 6 to 8 weeks. I'm with Drew Lansdown. I'm Brian Feeley. Nirav Pandya is off on load management. He did too many TV and tweets this weekend, so we're resting his hands, brain, and fingers. So welcome, Drew. Hopefully you don't look this wet just because it's raining hard for once in Northern California.
That's great to finally get rain.
So I thought this week, since we don't have Dr. Pandya, we would discuss shoulder arthritis, something that we don't really get in the pediatric world, but we see a lot, especially as sports medicine and shoulder surgeons. So my first question for you is, how common is shoulder arthritis compared to hip and knee arthritis, which we tend to see a fair amount in our older patients?
Yeah, I think it's traditionally not thought to be as common as hip and knee arthritis. You don't hear people talk about it as much. But it's even up to about a third of patients over the age of 60 will have some degree of shoulder arthritis. And it's increasingly more common. And I think a lot of it is probably historically we weren't as good as dealing with it from treatment. So you didn't hear as much talked about. But it's really something that, a lot of people deal with. It is pretty common and can be pretty limiting.
Yeah, so that's a good point. Why do you think it's increasing? Do you think it's our recognition, patients are getting older, patients are being more active, or is it really increasing because we're doing things differently?
I think part of it is probably us being better at recognizing it and then having better options to treat it. And then I think more too is that more and more people want to be more active as they age. So it's not giving up activities. It's, I'm going to keep going to the gym. I'm going to keep swimming, playing golf, doing these, activities that require your shoulders. Whereas I think before people may have been more okay with just letting those activities go, saying, sure, my shoulder hurts, I'm going to just stop doing this. But now it's like, I want to keep doing this and I want to find a way to, deal with the pain that's limiting me in these activities.
Yeah, I think that's probably totally true. A lot of times patients will say, well, I must have gotten the shoulder arthritis because I played pickleball or I swam when I was in high school. And it looks like, at least in reviewing the literature, we don't really know the etiology of shoulder arthritis. It seems like some people are, I don't want to say predestined for it, but there is a genetic component that we really can't control. It seems like some people, unfortunately, are exposed to substances that can increase the risk of avascular necrosis, whether that's alcohol, sometimes the medications we have to put people on for other disease conditions can predispose people to it. We know that there are some bony morphology things that we'll get to in a little bit, but that you may be predisposed in how the alignment of your shoulder sets up, similar to hips and knees. And we know that there may be a small component to your activities, but more likely whether or not you had a previous shoulder surgery or whether you had a dislocation where you were over tightened or never got surgery and you were dislocating a lot, and that instability led to arthritis. So when patients ask you, what caused my shoulder arthritis, what do you usually tell them?
Usually I'll just say it's hard to say. And I mean, I think unless you have a fracture at the shoulder, we know that that'll, disrupt the cartilage and, or, some big trauma like that. Most of the time you can't pinpoint one thing. And I think it's a combination of just, who they are, like what their cartilages look like, what their cartilage looks like, how the shoulder wears over time and, the activities that they do with it. And, it's really hard to be able to drill down, like, this is exactly what caused it. What do you tell people?
Pretty much the same thing, unless they have instability or they had a shoulder surgery in the 70s and 80s that over tightened their shoulder. And honestly, I usually tell them it doesn't matter. Like the things, let's say that you found out that playing pickleball, which was your passion for the last 5 years, slightly increased your risk of arthritis. Well, but if pickleball was your passion and it kept you active and healthy, and now you're no longer at risk for heart disease, you made 10 new pickleball friends, say, have at it. We can treat the arthritis, but we can't treat if your whole body is falling apart. So I think it's a good problem to have. And the reality is, I don't think activity has really been shown to be a source of shoulder arthritis.
Right.
So let's say, Drew, I'm, not in the not too distant future, I come in, I'm 60 years old and I've got shoulder pain and I've been told that I may have shoulder arthritis. What tools do you use to diagnose shoulder arthritis, both in clinic and with imaging?
Yeah, and so when we're evaluating people on their exam, the most common things to see are loss of range of motion. So having patients show us how well that shoulder is moving, and then oftentimes the side that you're complaining about will just have a little bit less range of motion, especially in the beginning. Sometimes you can also feel like a grinding, like crepitus, just where that joint isn't smooth, and you can feel that with a hand over the shoulder. And then really the best tool that's readily available to us is just an X-ray. And so the bony changes show up on X-ray. We see that, the joint space is narrow, may start getting bone spurs, have some other, markers like little cysts around the joint or thickening of the bone. But the X-ray is pretty sensitive and quick to get, safe, and gives us all that info.
Yeah, I think that brings up two important points. First of all, oftentimes patients don't know how much range of motion they've lost. They'll say, my shoulder is great, and reach up about halfway because their shoulders have a lot of redundancy. They can reach up. You can reach up and grab things off of shelves with only about probably 60% of your range of motion left. And the second thing is X-rays are really helpful. I think probably once or twice a week, I'll have a patient come in with an MRI, no X-rays, and they'll be focusing on something that's torn. Usually their MRI will say degenerative labral tearing, partial thickness fraying of the rotator cuff. And then they'll miss the part where it says severe bone-on-bone glenohumeral arthritis. Right. And they want, the soft tissue stuff fixed. I'm like, oh, actually, if you're going to have surgery, you need a shoulder replacement, not a shoulder debridement. But that being said, we are at an academic center where we do use MRI and CT scans. So what are your indications for getting these?
Yeah, so the MRI specifically lets us see those soft tissue structures better. And with shoulder arthritis, a lot of our decision making is based on what the rotator cuff is like. So both the tendon, the muscle, and MRI gives us a really good view of that. So if there's a question of, if there's also a rotator cuff tear, then I think getting the MRI can help answer that question. And then, the CT scan, right now, it's probably the best way we have to look at the bone in 3 dimensions. So it's like an X-ray, but just gives us so much more information. And the shoulder blade, especially, is such a unusual shape and can be really thin. And so when we're planning out surgery, the CT scan can, almost give us a chance to see what that's going to look like before surgery and do a lot of the planning prior to the operating room when somebody's under anesthesia, and can let us, figure things out, understand, what the surgery will look like, and do a lot of it ahead of time, which I think is great for patients.
Yeah, I think that technology has been really nice, especially for the more complicated shoulder replacements. We didn't really talk about it too much, but even though we look at how we treat most shoulders are pretty much the same in terms of you're going to get a ball on the ball side, a socket on the socket side, unless it's a reverse where those are switched up, there is a lot of pre-planning and kind of behind the scenes work, figuring out which is the right component for the individual patient. All right, so going back to me, I go to the hospital, I have a standard shoulder replacement. I guess backing up, can you tell people what the difference is between what we call a standard or anatomic shoulder replacement and a reverse, and what the indications are for each?
And so like you had just said, so the anatomic one, so the normal joint, there's a ball on the humerus on the arm, and then there's the shoulder socket on the shoulder blade. And so the anatomic shoulder replacement is just replacing parts like you had them before. So we put a new ball on the humerus side, and then generally a plastic socket on the shoulder blade side. And that joint needs the rotator cuff if it's going to work. And so if you already have a rotator cuff tear, then having that replacement is just not going to function. I'm not going to be able to lift the arm up. The joint's going to slide around more, wear out more over time. So a high risk of failure, not worth doing. And the reverse replacement is where we put a ball on the shoulder blade side and then a socket on the arm side. So we're reversing the orientation of the joint. And that's something that we've done in the US for about 20 years. And then it's been in Europe even longer than that. But It's a great option because so often patients do have tears of the rotator cuff and the other shoulder replacement just won't work. So this one bypasses the rotator cuff. The arm can function with just the deltoid muscle. And so you can still move the arm. The replacement helps a lot with pain, and can get a really, good functional shoulder, even if that rotator cuff is not sufficient for the standard replacement.
Yeah, I think that's a really good point. Oftentimes patients will come in and they'll be like, well, I don't want that reverse. It sounds more complicated. When I looked on Google, it was, if you can't get the good one, you're going to get the reverse. And even though this was a while ago, we did a study that showed the outcomes are pretty much the same. Like a well done total shoulder and a well done reverse for the right indicated patients function pretty much the same, with minimizing the complications. And I think where we get into trouble is two places. One is when we try to push the indications of a total and say, your rotator cuff looked good enough, or your bone loss wasn't that bad. And two, when we're probably overly aggressive about doing reverses when we don't need to. And I think we're still kind of fine tuning that. But anyway, so I'm getting a standard anatomic shoulder. My rotator cuff looked good. I usually stay overnight or sometimes even go home the same day. What does rehab look like for me?
Yeah. And
so keep in mind, I'm super athletic too.
So for an athletic patient, probably not for you, but for that like highly athletic person, that rehab, what we'll usually do is, so I think the hardest part is being in a sling for 6 weeks. And that is, for the replacement, we have to go through one of the tendons of the rotator cuff and then have to get that to heal. So we're really like protecting the shoulder for the first month and a half. And that's the sling. And I think that's the part that frustrates people the most, but then we, get through that and then things get better. And the rehab, usually people will start with physical therapy within the first week after surgery. And in the beginning, it's just like passive motion. So the physical therapist moving the patient's arm, or, using your other arm to move that without firing your muscles, just so the shoulder doesn't get too stiff. And then around that 6 weeks time point, when we're coming out of the sling, then it's regaining active motion. So getting the muscles to fire appropriately, control the arm, get the shoulder blade muscles stronger. So you're, again, positioning the arm where you want to actively. And then usually around 3 months can start strengthening, and then just progress up from there.
Yeah, that sounds like a long recovery, but the reality is I think that's the same for most orthopedic procedures. We just are a little bit more dogmatic about it for anything with the shoulder, because we're protecting that rotator cuff repair.
Yeah. And I think, during that whole period, you're like doing more, the shoulder's feeling better. And often, like much earlier, people are very happy that, they've gone through it. And like, especially the really arthritic shoulders, you're already not doing anything with it. So it's not really changing the function. It's starting pretty early on. It's just all improvement for a lot of people.
Yeah, I totally agree. The other thing is, you don't have that arthritic pain. As soon as you wake up, you have pain from surgery, but what you don't have is that bone rubbing against bone pain, because you have metal rubbing against plastic. So what a lot of patients will say is, yeah, it hurt, but it felt different. And that feeling different was enough to get me through that first week or two where I was really sore, because I knew I was going to get better over time. So you've done some studies looking at when people return to things like golf and tennis, and the groups out of HSS have looked at other sports. In general, when do you tell people they can go back to playing their sports, and how likely is it actually that they're going to be able to?
Yeah, and before surgery, usually tell people to plan on like 6 months. And then for, something like golf, can probably get back to chipping and putting earlier, like around, 4 months or so, just with like light swings. And, but, you do want to make sure that, you have good strength, good control, good motion before trying to do those like more complicated motions. So I think that's just going to put people at risk for, either overuse or re-injury, or, getting frustrated in the process. And, but so like having that like longer term plan, I think is good. And yeah, what we found was for patients returning to golf, if they had the anatomic shoulder replacement, it was more than like 90% were able to get back to about the same level. And then the reverse was lower. I think it was about like 75%, but still most people getting back to playing golf if they wanted to. So, we looked at people who previously played golf, and that was one of their goals of doing the surgery, was to keep playing golf, and also found that kind of their performance did not seem to be negatively affected by having the replacements. They were able to come back, same handicap, same driving distance, or hitting the ball like they want to, but then just hopefully doing it without pain.
Yeah. And I think the other studies looking at this have shown the same thing. Like if you want to get back, especially for things like skiing, jogging, doubles, tennis, you actually can get back, and the success rates are pretty good. They are somewhat predictive on, or predicted by, whether or not you were doing it in the past. So if I said, after my shoulder replacement, Dr. Lansdown, I really want to become a competitive golfer. I haven't golfed in 20 years. Chances are it's not going to happen afterwards. But if I said, hey, I play tennis now and again, will I be able to go back and do that? Absolutely.
Yeah.
So I would say 20 odd years that I've been doing orthopedics, if you include residency, there's been a lot of changes in shoulder replacements. When I started, instead of doing reverse shoulders, we did something called cuff tear arthropathy heads, where just huge heads shoved into the shoulder when you didn't have a rotator cuff. We went from cementing everything to usually doing press fit stems on the humeral side, which makes revisions easier. Our stems have gotten shorter, which seems to decrease pain. What do you think the next big advances are going to be in shoulder arthroplasty?
Yeah, I think, on the surgical side, two things. One, if we can find a way to let people accelerate their rehab earlier on, by more predictably getting that tendon in the front to heal, or heal faster, or be like safer to push through, I think that would really change the whole process.
And by that, you mean that rotator cuff repair we do when we're closing the shoulder.
Right. And if we could say, what, the strength that we have with this, you can come out of the sling whenever you're comfortable, use the arm, like that will not fail. If we could get to that point, then I think that'd be a huge improvement. And then, the other part is the socket is usually what wears out first. And it's in like the 10, 15 year range, we think right now, but having something that's more predictable there, that would, I think, let us tell that like 50-year-old patient with shoulder arthritis, like you can go ahead and have this done. Don't worry too much. The implant will have some longevity. And I think that's where, like hip replacements are right now, where, the younger patients can feel more confident getting that joint replacement. Whereas I think we're all a bit nervous for shoulder replacements in like a 30-year-old, a 40-year-old, that, this is probably a bit too early. If there's anything else we can do, let's hold off, knowing that the replacement's really what would make the difference in quality of life. What do you think?
I think that's a great point. I think the controversies for shoulder replacement are, what do we do with a 30 to 45-year-old patient, or 30 to 50-year-old patient, where they come in and they're starting to not be able to work. They can't do their activities. They can't play with their kids. And I think we used to say, basically live with it, because we don't want to do that revision 15 years down the line. And I think one of the changes that's has happened and will continue to happen is us telling patients, well, we need to be able to move the needle for you now and deal with the consequences 15 years down the line. So I think we're progressively getting better at treating those younger and middle-aged patients with arthritis of all joints, but particularly in the knees, hips, and shoulders. I think the other big advance is going to be to figure out how we can improve, and this is my bias, but the muscle quality around your rotator cuff. One of the things that you mentioned in one of the studies that we're doing here at UCSF is looking at, can we predict how your rotator cuff is going to function after a shoulder replacement by looking at you preoperatively to figure out who needs a total shoulder, who needs a reverse, who needs their total shoulder, but augmenting their rotator cuff a little bit, augmenting the muscle, and figuring out how we can actually leverage biology and the shoulder replacement, the arthroplasty part of it, to really give everybody a really good outcome. So we minimize those occasional failures that we have because the components weren't quite right, or the muscle or tendon wasn't strong enough.
Yeah, no, I agree. And then I think the other thing too is hopefully we have something to deal with that like early mild to moderate arthritis, because I think like hip and knee arthritis, there's this point where we don't know how to prevent it necessarily. And if it's early on where it's not quite appropriate for a joint replacement, we don't know. There aren't great options that actually modify the disease course. So, something that can slow arthritis, like really directly treat what's happening at the joint. Hopefully we'll get to that point someday.
All right. Well, thank you very much for taking time before you go to the OR. Hopefully this will be helpful for patients, providers, and people just interested in the wonders of the shoulder. So thank you for joining us.
Yeah. All right.